Your timing is perfect. Well done, especially for mostly academics. I'm impressed. 2 o'clock and we're all sitting down. That's amazing. Tell me where.
So you're just a bit further back, and then you're nicely lit.
So everywhere around here, I'm guessing. I can sit here.
Yeah.
Okay, but I can move a bit left and right.
It was just
no,
because you were coming a bit further forward.
Got it. Perfect. I think that's a good time to actually start with the event. Thanks a lot, everyone, for coming here today. Haven't had the chance to speak to a lot of you, but even a couple that I spoke, you've come from different countries, possibly even continents, so that shows what a great event we're going to have for you today and the reason for you coming here, so that's amazing. So welcome officially to the bioXcelerate AI launch. We're looking forward to showing you what we have for you today. A couple of things though. First, I'm Harry. I'm going to be your MC for the first half of the day. The second half is childcare duties for me, so Chris will take over for that half. A couple of housekeeping things. There is no expected fire alarm to take place, so if that happens, we just go out from the door that we entered and we see ourselves across the road. WC is right on the back, and we have Jamie somewhere, very close, there. Jamie, which is our first aider for any medical emergencies. Jamie's right there. We've got an exciting agenda for you today. We're going to start with some people from inside bioXcelerate. We're going to start with our CEO, Alan Crawley. Then we're going to continue with Chris and Zhana, 2 very important members of the bioXcelerate AI team. And then we have 3 amazing external speakers for you, Richard, Heiko, and Ricardo. I'm going to keep it immediately to the important stuff. You didn't came here to hear me talking. So I'll start introducing Alan. Alan is our CEO at bioXcelerate AI with over 30 years of experience in customer transformation across marketing and intelligent service consulting. He's worked with a lot of top firms, Accenture, PwC, software partners. He holds an MSc in biostats and an MBA from this university. And it's this background in both science and business that drives his results-oriented approach. So please join me in welcoming Alan to the stage.
The first item was not to fall down the stairs, which I almost didn't succeed with, but apart from that. So it falls to me to do the briefest of prologues for the day. And most importantly, just to welcome everybody to what for us is a really special day. It's the culmination of a huge amount of hard work, not only in a scientific and mathematical sense, but also just the business of pulling a team together and forging it and making it work and settling everybody in. I want to say hello and thank you to some old friends, some actually very old friends, long-standing friends who are in the room today. There's 1 or 2 very special people who've come along today, which I'm absolutely delighted about. A bunch of new friends. It's great to, and I'll meet more of you through the course of the day, and I'm looking forward to that. Very important also to acknowledge and recognize our academic and research partners and collaborators, because more of this later when Chris and Zhana and co talk about our work. But that matters a great deal to us. That partnership with academia and research and industry is really what drives us. So great to see everybody here today. And then very little of it would be possible without our clients and the pharmaceutical companies and others that we collaborate with and who help pay our way. So never taken for granted, never forgotten. and absolutely delighted that some of you are here today and dialing in, and also others who've been interested enough to come along and hear what we've got to say. So very much appreciated. And then finally, our incredible bioXcelerate team, which is a lot bigger than it was even a year ago, but still growing and still looking to kind of build that in a determined way over the coming months and years. So it's quite nice to have a little point of reflection when you do these things. And if I think back 2 years ago, the team consisted of one data scientist in the form of Chris Foley. And Chris and I I was introduced to this academic from Cambridge who was interested in doing something different. Chris and I hit it off pretty much immediately and had a shared vision of where we wanted to go with our data science and engineering venture. And in particular, we were really excited about the prospect of being able to do what we are doing here today, which is to build a different kind of business around life sciences and the innovation and data science and engineering innovation, mathematical innovation in life sciences. So lovely to be able to acknowledge that. We now have a team of 50, which is quite some going into a 2-year period. And the grey hair is age-related, but also activity-related over the last 18 months. And our plan is to double that in the next couple of years. So we're on a really big mission. BioXcelerate is a critically important part of that. And Harry mentioned a little bit of a past in biology and science and so on. So I'm very much the layperson here today, but it fills me with absolute joy to see how well the team have settled in, the work that we're doing, the acknowledgement and so on. It's just absolutely fantastic. So just kind of briefly reflecting on, what is it that drives us? So I think the biggest thing is purpose. So we are all excited about not just the technical aspects of what we do, but the purpose of it, which is to improve life chances, life outcomes in health sciences, and that's the biggest thing that drives the team. The innovation is a function of the power of data, the availability of data, the extraordinary scale of that. I think back, 20, 30 years when 30, maybe 40 years when I started out, it just wasn't possible. We didn't have access to the kind of data that we do now, and a lot of the mathematics was in place, but we didn't have the data. We've now got the data, and the innovation centered around that is super exciting. I think it's also really important to kind of reflect on the value, the importance of experts. So we talk about, being data scientists, being mathematicians, being scientists, but the context is everything. So the collaboration is all about working with leading experts in their field, leading experts in academia, and also in our industry partners. And BioXcelerate's our newest innovation area. So this is a big commitment for us, really, really exciting, and I can't be happier than I am today to see everybody in the room and to share this with you. It would be remiss not to also say thank you to Richard, to Heiko, and to Ricardo for giving their time today and helping us out with, no doubt at all, will be really interesting talks, and no doubt there'll be some really interesting discussion following on from that. So really, that's pretty much it from me, other than to say I hope you enjoy the day. There's been a huge amount of work's gone into this. Hats off to Leanne and Jamie and the team for everything that they've done. It takes a lot of effort to pull this together, so thank you, Leanne and team, for that. I will look forward to meeting everybody later on, catching up with a few people I haven't seen in a long time, and enjoying the day along with the rest of you. Thank you very much.
Thank you, Alan. By the way, I forgot to mention that one of the I don't usually do cards, but one of the main reasons that I wanted to do cards is the impressive background of all the people here, and I was afraid that I will forget something if I don't have a card. So we're going to continue with Chris and Zhana, our Chief Data Scientist at BioXcelerate and our Director of Health Data Sciences at BioXcelerate, two very important members of the team. A bit of background for each one before I introduce both of them for a joint talk, if I'm right. So Chris started with a mathematics degree from St. Andrews, completed a PhD here again at Edinburgh, focusing on creating machine learning tools to understand diseases like cardiovascular disease. He also spent some time in Cambridge as a research fellow, specializing in causal inference and human genetic studies. He's notable for creating open source ML software and using AI to solve Newton's equation of motion, showcasing his innovative contributions to the industry. Thank you for making us feel bad, Chris. That's great. Continuing with Zhana, similarly, she holds a PhD in maths and stats with a specific focus on developing methodology for analyzing multi-omic and neuroscience datasets. Prior to her role at bioXcelerate, she spent 4 years as a genetics data science lead, overseeing the R&D development of proprietary software for genetic data analysis and population stratification. And her work notably concentrated on neurodegenerative projects, including Parkinson's disease. Finally, Zhana has also spent nearly 2 years of experience as a senior scientist in translational genomics, where she led the integration of genetic evidence into target identification and validation processes using causal inference tools. So it would be great if we could actually welcome both Chris and Zhana.
Is the clicker working?
I'll tell you. No. It doesn't look like it.
Brilliant. So the intention was not necessarily to have a double act, but given that we speak several times a day, I'm sure we can pull something together, Zhana, and yeah, while we wait for the slides. I guess what I can add is obviously just to say a big thanks to Alan. Alan is a pillar throughout the whole of the organization. I have a handful of very important mentors for me personally in terms of my career, and Alan is definitely one of those. And it's been quite the journey, as Alan says, to go from single digits, as in, an integer 1, all the way up to 50 people across a small number of years. And I was obviously lucky enough to meet Zhana, who's really been an absolutely fantastic leader in the health sciences world as well. Right, so I can play on with a bit of clicking, I believe. Let me just do this. Clicking is not an option. This is where I get my tutorial. Okay. Wonderful. Okay, bro. Yes, so as I say, thank you to everyone for coming as well. There's quite an array of people here, actually. People who have helped us with our sort of, the development of our licenses for our products. So it's wonderful to have a couple of the legal team that have helped us here. There's scientific innovators, there's business innovators, etc. So very, very pleased to see everyone. I'm going to continue the discussion and be as quick as possible, given I've eaten in some of the time, to talk about improving health outcomes through cutting-edge scientific advancement. So any organization, study, technology, etc., has to be driven by an outcome. And of course, bioXcelerate are no different from that. And I thought sort of long and hard, a little bit with Sarush and Zhana, how we would bring this to life. So we're very much focused on health outcomes and people. Driven by data, driven through industry and the infrastructure there. So I thought maybe this map from a paper in 2016 in the Lancet might help us. So this is a global map, clearly. And what we have on the left-hand side, and the colors denote this, are different diseases and conditions that are most prevalent across different countries. And really what I want to bring to life here is there is no country that is exempt from having health issues, health-related issues. And there's variance within that as well. To bring to life the timeline with data and health outcomes and really our understanding, again, I'm going to turn to this 2016 paper in the Lancet. So what we have are age groups stratified by age bands, roughly 5 years, and we have 2 time points. So we have 1990 and 2016. And what we're really focusing on here is years living with disability. And what we can see is in 1990, there were a lot less years of people living with disability than in 2016. Now, there are confounding factors here. We're getting much better at measuring data, accumulating data, understanding disease. And the definition of disease is also a very sort of slippery exercise at times. But you can see, whichever way we cut this, you can see an enormous burden, particularly on society, to really understand years living with disability. 3.5 million people in the UK live with a rare disease. 15 million live with a long-term health condition. So even in this room, we will know people, we may well ourselves be living with particular health outcomes that we would like to advance our understanding of and also pull forward our ability to provide treatments and therapies and therapeutics. This inevitably takes us to the mechanisms with which we really drive forward the creation of new drugs. And all roads lead to pharma and biotech companies. So we've got to think clearly about what are their challenges, and bioXcelerate are absolutely focused on this. So from a drug discovery perspective, what's keeping people up in the pharma industry at night? And why is that important? Well, we're spending more money than ever before on trying to find new drugs, but actually our ability to identify targets is decreasing over time. The development cycle roughly takes 10 to 15 years. So COVID was an exception, not the rule. So the ability to find a therapy, drive it through the treatment cycle, the drug development cycle, the clinical cycle, normally takes roughly 10 to 15 years. And this is the thing that we're really focusing on, is the vast majority of our decisions that we make early on are wrong. And in fact, 1 in 20 are correct in that they go through all phases of clinical development into primary, secondary, and tertiary care. So we want to take that 5% and turn that into a much more healthy position. And it turns out, and this is why we're here really, is that targets initially with human genetic evidence are twice as likely to make it through that cycle. Now that measure is in its infancy, so we believe we can do a lot better than just twice. Of course, we are no company at all with that ambition, and our firm ambition is to be a market leader and go-to AI partner in silico drug target identification and validation. So what do I mean by in silico? I don't often just like to drop in some Latin. What I really mean is that these are data-driven targets. Fundamentally, a nice sort of statement. We've worked quite hard to refine. I think it was, regardless of how divisive the figure was, Churchill said, "If you want me to talk for 2 minutes, then write to me 2 weeks in advance. If you want me to talk for 30 minutes, write to me 5 days in advance. If you want me to talk for an hour, I'm ready and I'm yours." So actually getting sentences like that and popping them into position is quite a difficult one. But fundamentally what we do is we use advanced statistical and machine learning technologies to discover new drugs. That's the bit that we're focusing on. What are we famous for? This sounds a little bit egotistical, but the reality is that you cannot enter into this space without expertise. Health requires lots of time and effort. So as Alan said, I've been a mathematician for 20 years and focusing on health in particular for the last 10 years. And it takes a lot of time. The maths is one thing. The contextual relevance of the application is more important, far more important. So what we're looking at is developing novel mathematical solutions to understand the genetic basis of disease, to then therefore better understand the etiology of disease and effectively help pinpoint causal mechanisms in the form of genes, proteins, and ultimately the interplay between multiple disease biological outcomes that lead to disease. So we're building vast knowledge graphs, not too dissimilar to how Google sort of won the game in terms of search engines, etc. So what is our impact? It's all about accelerating time to insight. So data are there, the vast, pools, lakes, rivers, oceans of data are there. The ability to derive the insights out of that is an incredibly subtle and difficult mathematical, computational, biological challenge. And that's what we focus on. So we're accelerating the time to insight to draw out of the kind of reservoirs of data that we have. But our continued focus is now, and will continue to be, tautologically, driven by actionable biological insight towards making sure that we minimize the risk of failure in clinical trials. Big thank you to Sarush for putting together our cube and our go-to sort of sticker for bioXcelerate. So what I'm going to do is pull the hat up here. So I'm going to focus a little bit on bioXcelerate. So the reason why these three kind of elements, of course, element of academia and industry is well-founded. So the reason why the three exist is because we want to sit in the interplay between these two domains. So lots of innovation in academia, lots of innovation in industry. Historically, academia has been very open and transparent. We love to publish the latest and greatest in our thinking, right? We get lots of ego points from that, but also it's trying to move the dial forward from a scientific perspective. But the same innovation exists in industry. The distinction there is that often, for proprietary reasons, for commercial advancements, etc., and there are other GDPR issues, etc., we want to sit that data sit those R&D exercises outside of the public domain. bioXcelerate is here to straddle both of those. So we're very, very focused on open and transparent science that's applicable to the latest and greatest challenges in industry. So that's what we're doing. So how do we bring that to life? Well, let me just pull that leg and arm of the cube out to the left. So how do we bring that to life? Well, we have offices in the University of Edinburgh. We have wonderful collaborations with senior academics across multiple institutions in Edinburgh and beyond. We have, Professor Riccardo Marioni, who's going to be speaking later, who's been a long-term collaborator for bioXcelerate. We also work with Harvard MIT's The Broad Institute, University of Cambridge, Imperial College London. The connection between the Biobank in Finland and the Broad Institute is one that we've had quite a lot of success with. So really, we're positioning ourselves to understand where the forefront lies in an academic context, and then stitching that together over to the industry partnerships. So we work with 5 global pharma and biotech companies who are all processing and have implemented products that we have developed in their drug discovery pipeline today, just now, as we speak. And of course, it's the collection of these 3 dimensions that we're looking to position ourselves very firmly in. I'll leave you with this. The way I view this, and I think we collectively can sort of, again, a compact sentence here, is we're looking at this from a 21st century business model in the health sector. So that is open and transparent research for the scientific and industry communities to enjoy, to peer review, to make sure that we're watertight, but to deliver that with commercially positioned products. So the advantage here, and this might not be particularly well known, is that when you build and develop a novel algorithm, say, that sits outside of application, there might be wonderfully appetizing and mouth-watering scientific mathematical insights, but the ability to translate that into something that sits within a pipeline, that practical implementation, can require huge amounts of adjustment and re-maneuvering. So if you start with the outcome and drive the science along with that, you're minimizing the differential there, and that's what we're doing. So we've published in some of the world's top journals in Nature, along with some of the world's biggest and most well-known pharma companies, and working and leveraging insights from biobank initiatives like the UK Biobank, which is a wonderful resource for the UK and for the world more broadly. With this, I will hand over to my esteemed colleague, Zhana Kuncheva.
Thanks, Chris. Do you use? Right, okay. Thank you, everyone. First of all, I just want to highlight how important is what Chris just talked about, which is our motivation and why we are here. and the underlying reason why we're doing all of that. So now I'm going to talk a bit more about how we are bringing that ambition to life, or essentially how the magic happens. I'll briefly explain that bioXcelerate is part of the advanced data practice at Optima, which, as Alan and Chris said, is now more than 50 highly skilled data scientists and engineers that work all together to combine their expertise and deliver fantastic solutions for clients across 5 different industrial sectors, of which the pharmaceutical is one. In bioXcelerate, what we're working on mainly is addressing challenges in translational genomics, precision medicine, and digital health. And we're doing that by leveraging all of that intersector expertise to guarantee impact at scale. We do that by working together with our colleagues at the machine learning and decisioning science division that help us to deploy some deep learning and computer vision solutions. And we're also achieving that by working with our colleagues at the data and software engineering department, and that are making sure that actually our impact is also at a computational scale. So now I'm going to try to put this framework together, put some faces to it. A lot of the people on this page are here with us today. And why all of this is possible, why combining all of that talent is possible, is due to Chris's idea when he joined the company, and he planted the seed that, well, Optima is doing a fantastic job in data science, we can expand to healthcare as well. So that seed germinated down the company, and a lot of people want to join our journey. So if you're interested in talking about our commercial and strategic view and plan, definitely go and chat to Sarush or to Andrew Campbell. We're also joined by some of our scientific advisors today, so Ricardo is going to talk a little bit later. But also Olivier, which is one of our clinical development advisors, flew all the way from France, so I really recommend you go and you chat to him. If you're interested in some of our products or day-to-day machine learning and data science capabilities, I recommend chatting to Surush, Manju, Daniel, Michael, and Peter that have been doing a fantastic job, and due to which all that's possible. What's very important is that we have built a community of peers, and our expertise complements each other. And this is how we guarantee that we deliver absolutely outstanding solutions for our clients and that our products are of utmost quality. So once you have all of this talent together and all these exceptional skills, you kind of have to find a way to funnel that and to realize it and to translate it to your clients so that they can get the most out of it. And we discovered that we have a very flexible way of working to achieve this goal and essentially to meet our client needs. We discovered that we are very good at combining both service and product to make sure that our clients are happy and that we are delivering the best solutions to accelerate time to insight. And I'm going to tell you a little bit more about what service and what product is. So through service, what we mean through service is that we actually work shoulder to shoulder with our clients on a daily basis. And in this way, we're actually managing to populate the scientific innovation gap. From a product point of view, we realized that we can actually, by designing products and delivering those to our clients, we can populate the technology and insight at a computational scale gap. And through combining these two approaches, we are actually guaranteeing real life impact. So just to now, you ask, well, we have been doing all this great work and you're talking about it and you've been doing it for a while. Why are you doing your launch now? Well, it took us some time to realize that actually service is fantastic and it's very impactful, but building product guarantees that you can also propagate across the industry. Rather than 1 or 2 people or 2 teams in pharma company being able to scale up a solution and run it for 5 hours rather than 6 months, we can now try to drive the whole industry forward and have real impact. So building that product, engaging all of the engineers and the product team took us some time, and we thought that when we complete that, which we have completed this week, and it's a big achievement for us. It would be a fantastic opportunity to also officially launch our brand, which is now about our motivation and our ambition combined with our products. Pliograph is essentially our flagship product, and the main aim of it is to try and combine all sorts of multi-omics data from transcriptomics, proteomics, methylation, disease phenotypes, and try to pinpoint the causal row of genetic variants that's driven by this multi-omic data. I'm not going to fall into details. Feel free to reach out to the team. I'm sure they'd love to chat to you about it. We also have a lot of information about it on our website. But what's more important is actually the impact of that work, and that Pliograph is used to accelerate time to actionable insight in drug discovery, and it also enables us to de-risk the drug trials, clinical trials process in drug discovery. So it's really helping us to achieve our bigger goal and ambition. What's interesting about Pliograph is that for it to work properly, we had to develop some other products on the go, and one of them is also SwitchStep, which was designed to address the challenge of both accuracy and speed of genetic fine mapping. Now, for those of you that don't know what genetic fine mapping is, this is an approach to try and pinpoint the causal genes that are actually associated with disease and outcomes. And we have managed to reduce the process of a large-scale fine mapping from 15 days down to less than 5 hours. We achieved that with more than 99% accuracy, and we guarantee a computational convergence, which already brings us one step closer to our bigger ambition. We also launched another product, which is called ImpMap, and it again addresses challenges of accuracy and speed, but this time in genetic imputation. For those of you that don't know, genetic imputation is the process of populating gaps, missing gaps, in your data that might be driven by technological biases such as missingness or low quality of the data. We managed to reduce a process that can take up 2 hours down to seconds, and we did that by achieving greater accuracy than standard approaches, reaching on average more than 97% accuracy across all types of multi-omics data sets. What this means is that by now being able to have a full, complete picture of the data, we can enable a complete downstream analysis on identifying the right targets. So to wrap all of this up and these fantastic products that we have worked with, our team, with their complementary skill sets, introducing best practices, best engineering practices, best scientific practices, combining them in product and bespoke services, we do believe that we have managed to accelerate time to actionable insight for human genetics in drug discovery. And today, together with you, we want to vouch for our next big ambition, which is trying to go beyond the twofold improvement in discovery success. So we believe that by deploying at the mass level these solutions, we can actually get a greater discovery rate and success rate for drugs entering clinical trials. Through that, we believe that first we're going to save billions of computational full-time employee hours in running those analyses. We also believe that we're going to increase health equity in drug discovery through tools like Pliograph that enable analysis not only in one ancestry, but across different types of ancestries, so it can be more inclusive in your analysis and account for diversity in populations. And we also believe that through these approaches, we are going to reduce the lab-based scientific resources that are timely and costly for the industry. So, Chris, I'd love you to contribute to anything else that you believe I might have missed. Okay. So,
Pro.
Thank you very much, everyone.
Thank you, Chris and Zhana. That was also, from my perspective, a lot of the faces that you saw on that slide that Zhana showed with the collaborative team and the different skills and experiences. A lot of these people are here today, so feel free to spend some time later with them during the networking event to find out more about them. Next up, we're going to have Dr. Richard Wyse. Again, a bit of an intro and preparation before the slides appear there, Jamie. So Richard joined Cure Parkinson's in 2007 during the early stages of the charity's formation. Transitioned from a background in cardiology and genetics, and he shifted his focus towards Parkinson's research. Recognizing the need for innovation in that area, Richard spearheaded the development of an innovative program known as the International Linked Clinical Trials, and his efforts have been instrumental in transforming the landscape on neurological research. To date, over 4,000 individuals with Parkinson's have participated in this research, with recent trials showing promising results, and that includes those involving type 2 diabetes, medications, and drugs used in liver disease treatment. And wait for it, in recognition of his contributions, Richard was honored this January with a member of the Order of the British Empire for his services to Parkinson's disease medicine. So if we can all welcome Richard right now to the stage.
Thank you for that obituary. Can I have the first slide? Well, thank you for inviting me to speak today. I hadn't seen that text for some time.
How do I check?
Look, I've picked up on the various titles that the bioXcelerate want to cover today, and I've interlaced them.
Sure, Richard, just check something on your...
Sure.
Where's your mic? Now it's working. Am I right, Jim? Perfect.
Okay.
Yeah.
I want to pick up on what the agenda is that bioXcelerate has set for us. I want to give a view from the non-profit sector, because one of the later speakers wants to give a view from the academic sector. So we have a huge number of uses for AI and for machine learning in what we do. And I'm going to give you, it literally could have been a one-week lecture, because there's so many, Parkinson's disease is incredibly complicated, and finding our way through it. Back in 2007, when I started with Cure Parkinson's, neurologists who treat Parkinson's patients were telling me, why are you trying to work on a cure? You're only going to give patients false hope. Well, it's changed now, and in a few weeks we're going to publish a paper where we've completely stopped disease progression at all, and we're making inroads in quite a large proportion of patients. So for us, that's spectacular, but there's so much more work to do, and AI and machine learning have got a huge part to play in it. So that would be forward. No. Okay, I just want to explain who we are. So we're a funding charity. We fund preclinical and clinical research into many disease-modifying therapeutic approaches. A large number of drugs that we're testing. We fund globally, whether to academia or to industry, and in both the pharmaceutical, RNA, and regenerative medicine fields. We co-fund clinical trials with various federal and state governments, other charitable organizations, and many pharmaceutical and biotechnology companies, in the sense that a lot of pharmaceutical companies have given us drug and placebo for the trials that we've done, which has saved us tens of millions of pounds in drug costs. Every year we write an update on what sort of clinical trials are going on in Parkinson's. And this was from about a year ago. We're just assembling the 2024 update as we speak. And one of the graphs that we show, diagrams that we show in these papers each year, is how many, and the nature of this. So symptomatic therapies are at the bottom. I'm going to try to move away where I don't reverberate. So these are given to patients every day to make their day better, but they don't stop patients getting any worse year by year. So the symptomatic therapies are at the bottom in various phases, and the disease-modifying treatments are at the top. I think it's fair to say that we've been involved with about 40% of these in one way or another, whether funding or in, some sort of involvement. So our footprint in disease-modifying therapies is huge, and we probably run, it's difficult to calculate, we probably run the biggest drug repurposing initiative in the world. So this was mentioned before. We run this international linked clinical trials initiative, and we've been doing it for, I think, 12 years now, to evaluate, prioritize, and repurpose existing and new developing medications that may have benefit in Parkinson's. So we've published a lot of papers about this, and we have a huge key opinion leaders group. These are the good and the great in Parkinson's, typically professors of neurology who also have huge cutting-edge labs in various areas. So we've got about 5 more recruited since this slide was made, but it's a very big group. We have face-to-face meetings for 2 or 3 days every year, typically in Michigan, and we decide what drugs we're going to put into trial next. And this is a typical vote. Every one of these colors is a committee member vote for a particular drug. So we write these very, very thick dossiers about each of these drugs. And we have tried to use AI to do that, and I'll come on to that in a second. But they're hugely curated about the drug mode of action, but also safety and pharmacokinetics and much else besides. So, but this is a process by which we decide which drugs to put into trial. And this was done, I don't know, 3 or 4 years ago. Just took it at random. Quite a lot of those drugs are currently in our trials. So we've become known for our GLP-1 trials. We've done a lot of them. Exenatide is used to treat diabetes. And we've done, I think there's been about 5 or 6 trials now. We're currently just finishing our phase 3 trial of this compound, but we've looked at various other drug classes, various other drugs in the GLP-1 class, including liraglutide, which we did a trial in Los Angeles, and lixisenatide. We did that in 21 hospitals across France in patients soon after they were diagnosed. We've done trials that are patients are much more severe, further into their disease. And yes, and this is in the same, it isn't quite the same drug class, but it inhibits an enzyme which impacts with that drug class. This trial is a multi-arm trial, so we have multi-arms against the placebo, and all those drugs are over-encapsulated, so no one knows which drugs, who's getting which drugs. But alogliptin we're doing in Australia. Australian government gave us about $30 million to set up a big 5-year program there. Well, this is about half or maybe a third of some of the trials. You can see it's busy. I think that's all I really should say. So the theme of the meeting that bioXcelerate have asked us to address is how healthcare organizations, that's pharma, charities, NHS, can utilize AI and machine learning products to accelerate and increase the efficiency of drug discovery and development so that patients can get efficacious treatments more quickly and at lower costs. So those are bioXcelerate's words. So, but when we think about it, the perspectives of those different organizations differ greatly. So you're going to hear from academia a bit later on this topic, but also the time frames outlined above span a decade or more. So drug discovery from lower cost when the healthy economists come in at the very end. We heard in a slide earlier, it's 10 to 15 years. So we think that AI and machine learning have got their places in all of those various stages of drug development. And we're involved in all those stages, every single one of them. The drug discovery and the chemicals, changes of structure of the drugs, right the way through the clinical trials, and the health economics. We, in one way or another, we deal with all of those, and we think that AI and machine learning is really going to make a huge difference. So I want to give some examples of how we, a global charity, work with around 60 pharmaceutical and biotechnology companies, but we also work indirectly with hundreds of hospitals, including the NHS. Some of our trials involve 80 or 90 hospitals around the world. So I want to give some examples, and they're almost picked at random because, as I said, I could give a huge number of examples, but I've just taken a few. And one thing I would say about Parkinson's, because I did work in an easier therapeutic area early in my career, and it is immensely complicated, and so are a lot of the other neurology conditions, and we only have rating scales for much of the clinical observations, and I'll come on to that in a second and how AI can help. But we've had to find our way in lots of these areas where no route was we had to imagine how to go forward. I think Carl Gustav Jung said, if the path ahead of you is clear, you're on somebody else's path. You know, somebody else is your boss, and they've told you what your path is. But if you're creating it, you've no idea. You just find your way. And we've had to do this in various areas of medicine and drug development. So one thing I want to pick up on is better, more reliable diagnosis of Parkinson's patients. So this is more of a hospital thing, but it's very important for our recruitment to clinical trials. So it happens that sometimes it can take 2 to 3 years to confirm a diagnosis of Parkinson's disease, since there are other conditions that look very similar in the early stages. So I'm going to talk briefly about machine learning approaches to improve clinical diagnosis, so you can nail the diagnosis, cut out those 2 or 3 years. AI and machine learning enhanced approaches for biomarker analysis. So that's also, if you get good biomarkers, then you can help diagnose patients. But you can do a lot more because you can monitor patients in clinical trials, and you can decide what patients should get what drugs. So really taken at random, because there's a lot of machine learning and AI studies, but this one is a machine learning method to process voice samples for identification of Parkinson's disease. So what we've got here is normal, healthy individuals on the left and Parkinson's patients on the right. Now, this was published in the paper, and they picked a lovely, clear diagram where, to our eyes, we can see there's a difference here, and these are fast Fourier transformed spectrographs of voices. But they can pick this out even when it's quite obviously, to our eyes, we can see a difference, but the AI can pick it out even when it's far more difficult to pick out which is the patient from the controls. So we've been working for many years on biological samples that will be informative for Parkinson's, both to diagnose and to use as markers in clinical trials, and to use as markers for whether the drugs we're giving them are working properly. So this was very recently published. Alpha-synuclein is a protein that we all need. It's used to release hormones and neurotransmitters. It's part of that release process, and it does a few other things. But it can form clumps, and it can turn from what we call monomers, single lines, and they can form dimers and tetramers, and then it makes cells dysfunctional, and that's most Parkinson's patients have got this problem. Not all of them, but the large majority. So as we speak, we're trying to redefine Parkinson's based on the biology. So we take samples from spinal fluid. We'll probably be able to do this in blood samples on a regular basis to come. And this is extremely important for the field, because once you can nail down a biochemical marker that's really informative, and you know exactly in which patients it's informative, then that breaks open a lot of how we design the trials and how we choose to give which drugs to which patients. We've been doing some exosome analyses where in some of our trials, these are released by the brain. If you think of membranes in the brain, there's a gene called BIN3 that just nips off a little vesicle, and out it comes, and we finishes up in the spinal fluid and also in blood. We analyze the contents of that, because it's actually contents of the brain that are inside those vesicles. So we're using this as a technique to understand the results of some of our trials. That's worked very well. I want to talk about some of the databases we have at our disposal. So the first one that was set up was the Parkinson's Progressive Markers Initiative, PPMI. And this is patients with Parkinson's year by year give samples and have all sorts of clinical examinations and imaging. And this is available for everybody. It's open source. And so we can do some wonderful work on this. And so far there's been more than 200 papers, scientific papers, published on this data alone. So you can see how informative it is when open source patient data like at great volume like this comes out. So this is GP2, which is related to PPMI. GP2, think of it as hundreds of geneticists in 70 or 80 countries around the world, all piecing together, because there are geographic differences in the genetics that are related to Parkinson's. And one of the forms of Parkinson's is aligned with an Ashkenazi and Sephardic Jewish heritage line. Another one's come from North Africa. Of course, they spread. Another one's come from the Philippines. So the GP2 program is hugely funded, so about 400 PD geneticists are flown into a particular location. The last one was in Copenhagen, took over a huge hotel for best part of 4 or 5 days. And they presented all their data to each other. And there are about 40 subgroups, and they've been given tasks, and a lot of it's being written up. And so what is currently known is that there are a few main causative genes. And most of those have got mostly incomplete penetrance. And alpha-synuclein, you can get mutations to that gene, but you don't always get the disease. That's what incomplete penetrance means for the non-geneticists here. But there are about another 150 known genes from all this work. So many people working on this now from around the world. We've got 150 genes that add to the risk of getting Parkinson's. However, by adding expression quantitative trait loci analysis and additional transcriptomics to the classic GWAS techniques, which find us those genes, and applying AI and machine learning approaches, a large number of additional PD-related genes have now been discovered. Not published, but they're discovered. But a colleague of mine, Anthony Cooper in Sydney and Justin O'Sullivan in Auckland, published this not too long ago, discovering genetic mechanisms underlying the co-occurrence of Parkinson's disease and non-motor traits. And they've used these techniques to add to what we can do from classic genetic analyses. And this is some of their work in that paper. So I'm just signposting it for you. I don't have time to go through what is a very impressive piece of work. So let's move on to ASAP. ASAP is related to PPMI and GP2, but this looks more at the underlying biological mechanisms, and it's all funded under the same umbrella. And I don't know if I'm even allowed to say how many billions of dollars has been invested in this program, but what I can say is that it's all open access as soon as the analyses are complete, which is phenomenal. And I'm working on a project with them that it will produce literally millions and millions of samples. And as soon as it's all assembled and analyzed, I can't say what it is, but that will all become public domain. That's the idea, and that's how this huge funding exercise that is ASAP, GP2, and PPMI is configured. And I wish other therapeutic areas had this, but they give us so much data that we can work on, absolutely primed for use in AI and machine learning approaches. So here we can see ASAP, Collaborative Research Network. That's basically about biological mechanisms, GP2 and progressive Parkinson's markers initiative. So let's move on to drug discovery. Again, just a little snapshot, but also drug modification. So we were using forms of AI from 2013 right way through to 2021. And I'm delighted to hear that Olivier Delrouze here. Put your hand up. Olivier. So I haven't seen this man for 8 or 9 years, and we worked together. We helped each other on some projects that is totally related to this, and some other things that you were doing in other therapeutic areas. But come and see me later. We'd love to talk to you. So, our own curation of our big dossiers that we present to our international committee led to discovery of lots of new disease-modifying drug candidates. And for a decade, that diligent curation, just sitting down for a year and writing a support for the disease-modifying potential of a particular drug because it's got this biochemical property and it works like this in asthma, and that's linked, and just forming what AI should be doing much better than we can. But our experience was we wrote about 220 highly detailed dossiers like this over a decade, describing these candidates for our international committee, and we've launched a huge number of trials through that process. But over that decade, only 1% of those dossiers came from AI approaches, because curation was doing better for us. But it's clear that proportion is now dramatically going to change, and AI will in this particular area, it will help us amazingly that we don't have to write for months to run research to get this done. Another issue is where AI and machine learning is set to help greatly is the modification of the structure of certain drugs to grant them more appropriate physical chemistry or other properties that we need to be able to put them into patients. So for us at Cure Parkinson's, Farnesol is a good example. So Cure Parkinson's funded a drug screen. We knew that this protein, Paris, which was suppressing the number of mitochondria in cells, because you need mitochondria because it provides energy. It was suppressing that, and it was suppressing another very important biological process. So when Paris went up, then these other important processes went down. So that if we could inhibit Paris, then, and Paris is a very long acronym, but it starts with, I think, Parkinson. We wanted to find an inhibitor of it. So we funded Valina and Ted Dawson at Johns Hopkins in Maryland to do a drug screen, and we screened 230,000 drugs to find an inhibitor of Paris. Actually, we found 7, but 6 of them we couldn't give to man because they weren't safe. But the 7th we could, and it was called farnesol. And I wrote this, this commentary with Ted and Valina, talking about how we would get this into patients. By then we realized that, okay, it's a fantastic inhibitor, but we did need to give patients 27 grams a day. Yeah, not practical, is it? So we were looking at nano formulations, and we were looking at other ways to change the molecules slightly so that it got through the gut and it got into the brain much better. And in the end, we found that we couldn't really do it. I mean, maybe some fantastic structural chemists could, but so last year I found myself walking the halls of MIT talking to RNA specialists who could do that for us by a completely different approach. But AI could have helped us get the structures right so that we could get more of the drug from inside the gut, or we could have injected it. Same problem, it wouldn't get into the brain very well. We think that an AI approach would have been, if we knew how to do it at that time, would have been good. But we're now on an RNA track for this very important biological target. So let's move on to understanding biological mechanisms in Parkinson's. If we don't understand the biological mechanisms, we're not going to deliver the right drugs to the right patients, because we're not going to understand why they're working. So we feel we need AI and machine learning approaches to help us understand certain fundamental biological processes far better. We can see where we're failing to understand the biochemistry of this, and we just need some help. It's just hard to work out how some of the drugs are working and what compartments they go into and how they affect this, and what mechanisms come in to replace what they're, there's compensatory mechanisms cutting in, and all. It's very, very complicated. So there's the lack of clarity about poorly defined patient groups is a very good example of this. How do we select which patients will clinically respond well to which drug? So I mentioned to you the problem in neurology. I mean, if you're in cardiology and you're using a blood pressure drug, your patient's got a blood pressure of 165, you give them a drug, you get a hard number, and it comes down to 131. So measurable. What have we got in neurology? And I'm talking also about Alzheimer's, multiple sclerosis, epilepsy, motor neuron disease. We've got rating scales, and the neurologist sees the patient and he rates from only 0 to 4, speech, facial expression, rigidity, finger tapping, hand movements, toe tapping, leg agility, posture, and the list actually goes way down here, and that's only 1/4 of the patient-related list. And then we've got other rating scales about sleep and cognition. So rating scales is not a good way to be running medicine. So what do we do when we've done a clinical trial and we've got 2 groups of patients here? They've both been on the drug. We've got placebos somewhere else on another slide, but these have all been treated. So this group of patients, 65 to 70% of them have a clinically meaningful improvement. In other words, those rating scales have changed in various, you saw so many rating scales, but they have changed enough for the patient to feel the benefit. You might be able to measure it at a lower level, but if the patient can feel it, that's a really important thing. So we've got one group of patients with 65% of whom respond with a clinically meaningful improvement. We've got another group, only 30% respond. And also, we've got 10% of clinically meaningful worsening in that group as well, which we don't have in that one. So this is, so I went to other experts. This drug is used in other therapeutic areas. So I went to the experts, the world experts in that therapeutic area, and I said, look, we've got this group, and you know, can you explain it to us? They said, well, yeah, we got the same. We was hoping you'd explain it to us. So it's just a puzzle that we have to solve, and I think the answer is in a detailed analysis of the data. So we're just next door to the Wyse Center. I walked past it in the rain about an hour ago. How are Wyse going to help us? Well, this paper was published fairly recently. Application of Bayes approaches in drug development, starting with a virtuous cycle. So the structure of clinical trials in neurology is almost obstructive. Partly because of the rating scales, but also if you're seeing benefits, some of our trials go on for 2 years, some for 3, because the rate of decline is maybe, let's say 5% per year per patient. So if you're comparing that with a control, it's very difficult to separate it out after a year. We can do it, and we have done it, but 2 years is better, and the 3 years is even better, except that the patients start to change by the 3rd year, depending on the severity at the beginning. But Bayes' approach is, if we introduce them to Parkinson's, and we can do this retrospectively over hundreds of clinical trials, will allow us to shorten our timelines and allow us to bring in historical control data, allow us to do a lot of things. This was really helpful in the COVID vaccine story, and so I'm looking forward to improve our clinical trial design massively by going through the data of hundreds of clinical trials, some that we've done, some that others have done, and I think some sort of machine learning approach here would allow us to shorten our trials. So patients just meet the timeline for change, and then they've passed that Bayes test. And so we can shorten the trials, which makes them millions of pounds cheaper as well. So I think I'm just coming on to the end now. So use of AI and machine learning in deciphering biological processes in Parkinson's. So understanding and manipulating the properties of drugs of clinical interest for slowing disease progression. An example of widely differing clinical properties of drugs in the same drug class that exert very different responses in patients. So I'm using GLP-1 as an example here. So these GLP-1 drugs are used to treat diabetes, but some of them are also used to treat obesity by creating a lot of weight loss. So we funded this study 2 or 3 years ago. We showed with, 120,000 patients in the UK and in Hong Kong that patients can be prescribed 5 or 6 different medications for their diabetes. But if they're on a GLP-1 agonist, it mimics a gut hormone. They are 50% less likely to get Parkinson's. That's huge. That's a massive protection. And if they're on the other drug that I showed you earlier, alogliptin, which inhibits an enzyme that breaks down natural GLP-1 in the body, then you're 40% less likely to get Parkinson's. So that's a big difference. So I'm currently designing with some others in Canada and Korea a clinical trial of prodromal patients, which are Parkinson's patients that haven't yet got the tremor, but they've got some of the sleep disturbances, they've got some of the gut issues, and they've all had loss of sense of smell that tells you that they're 85% likely to be on a track to get Parkinson's. So I want to give these GLP-1 agonists to those patients before, and maybe I can prevent them ever from getting their motor symptoms and their tremors and their stiffness of movement. So also in the GLP-1 drug class is semaglutide, which is widely used now, not only for treating diabetes, but for weight loss and lots of other things as well. And then there's the Lilly drug, tirzepatide. Very similar results, 15 to 20 kilograms per year lost in someone who takes these drugs. I don't want my Parkinson's patients to take these drugs because they're going to lose weight and they're thin to start with, typically. But there's another reason. Exenatide, called Exendin-4 here, and lixisenatide, those structures are very similar. Only a tiny change of the structure of the natural GLP-1 drug that has brain receptors. It's released by the gut. And these drugs have been changed by just 2 amino acids, I think, to stop enzymatic breakdown. So they normally, GLP-1 is released as a hormone. Within a minute or two, it's been completely broken down by the blood. It does its job and then it's destroyed. These stay active in the blood for many hours. So that's why they can offer neuroprotection for over a 24-hour period. They get into the brain. So we've got here blood, and at the top, brain, and in the middle there's this blood-brain barrier that stops things like viruses and large molecules, bacteria, stops them getting into the brain as a protective process. Exendin-4 and lixisenatide and some of the others cross the brain because they're straight-line GLP-1 agonists. These are also called GLP-1 agonists, but they've got this tail as part of their structure. Semaglutide here, it's been the success story of the decade, really, certainly financially. But it doesn't get into the brain at all. It doesn't get in, it affects the brain by certain neurons called tanocytes, which come from an area at the bottom of the brain which senses the nutrients and the hormones in blood. It doesn't actually get into the brain to protect the neurons like this. So the 2 at the left show no entry into the brain. So what we can do is start to redesign some of these hormones. And I think we need AI to do that. But we do have exenatide and lixisenatide, which we can start to give to patients as soon as we've got regulatory approval. Okay, so I think perhaps I should just stop there. There we go. Well, all I wanted to say now is that I've shown you diversity of areas that we don't understand, that we've found ways to make inroads, and we're beginning to help patients. And we think some of these treatments will get into use by regulatory approval. But even when we've done that, we've only affected benefited maybe 30 to 40% of all patients, and we still don't know whether these drugs will last for years and years to be neuroprotective. So there's so much more work to do, and I'm really looking forward to working with bioXcelerate to deal with it. Thank you.
Thank you, Richard. A very, very exciting talk, and also to see some of the ways that, AI, big data, mathematics is actually used to improve the management of people with Parkinson's disease. Moving from that, we're going to move to another very interesting talk, and our speaker is online. Hopefully, Jamie will multitask on the back, and we'll see Heiko from, I think he's in Germany. The topic that Heiko will speak to us about is leveraging population-scale biomedical data to accelerate the discovery of novel drugs. In a brief intro, Heiko Runz is the speaker, formerly head of genetic epidemiology and currently medical director at Biogen, specialized in translating genetic findings into drug discovery and clinical trial design. Heiko's approach involved leveraging human data obtained through large biobanks, disease registries, and real-world sources to strengthen therapeutic hypotheses and ensure that clinical programs were conducted in the most informative patient subgroups. As a board-certified medical geneticist and translational scientist, Heiko possesses extensive experience in all aspects of clinical genetics with foundational trainings in pediatrics. Finally, prior to his industry tenure in 2014, Heiko served as an assistant professor and independent group leader at the Institute of Human Genetics and in the Molecular Medicine Partnership Unit. It will be really nice if we welcome Heiko online. He's not here with us. It'll be nice to do that.
Hello, everyone. This is Heiko. Can you confirm that you can hear me? Hello, can someone confirm that you can hear me?
Yes, we can.
Fantastic. Yeah, so I think the Optima colleagues have said that they would be able to drive the slides.
Yes.
Fantastic. Okay, great. So maybe you can just show the slides.
Can you see them, Heiko?
Now I can see them. Yes. Okay,
Perfect.
Great. Oh, it seems like when I speak up, the slides disappear for some reason. Don't know how I changed the.
Is it possible maybe for you to open your own PowerPoint slides and we'll always be at the same page with you? You can tell us when to change the page?
Yes, we can try to do that. So I'm now moving to the second slide. So it's the I guess just as an introduction, thank you very much again, Chris, Zhana, and team for inviting me. It's a real privilege to speak at your launch event. We have had a great collaboration, extremely fruitful, very energetic and engaging for several projects in the past when I was still working at Biogen as their head of human genetics. I understand Ben Sun is also on the call, who has been closely collaborating with us. And it's really an amazing story how far you have brought now bioXcelerate. And I wish you really the best of success to replicate these type of activities also with other partners, because there's a clear need for that in the pharmaceutical industry. And that's what you hopefully see on this slide, which is that creating really transformational new drugs is a really difficult thing to do, because more than 90% of the drugs that we are actually bringing into humans fail clinical trials. This is primarily because we have issues with efficacy and safety. To often predict that the drug is actually doing its job often depends on animal data and information that is not directly replicating in humans when we invite them into clinical trials. And in addition, there's some safety issues that are often just not easily predictable in the cell or animal models that we use before we start clinical trials. So don't know if you can do a next click, but you should see that essentially we are picking the wrong targets. And then you can move to the next slide, which is that drug targets with human genetic support have higher successes. We've already heard by this from Chris. I don't have the option to switch on my camera. My apologies. So this was not given to me as part of this webinar. I just got this information. So I unfortunately have to continue apparently blind. It's fine. You're not missing much. You would just see me. But I hope you can see the slides. And if you click probably 3 times, you should see the full slide, depending on how we define genetic evidence. We can eventually increase this probability of success depending on how confident we are that we are really having a clear link between a variation or several variations within a gene and the disease of interest that we are trying to address with a drug. And it's essentially how close we can come to build a drug that closely simulates a genetic link between a variation in the genome and a risk for disease. And that this is genetics is there to stay for drug discovery is really evidenced by that over the last couple of years, we have really a large percentage, actually the majority, about 2/3 of FDA approvals that are with drug targets that are supported by genetics. Next slide, please. So there are several sources where we can get to genetic data. Richard has really nicely introduced Parkinson's, and one way to access genetic data is through disease-specific cohorts, and clearly Parkinson is one of the front-runner diseases overall. We also leverage genetic data by genotyping and sequencing individuals who participate in our clinical trials, but more and more we are utilizing data as it is being ascertained in very large scale population biobanks, the main topic that I want to speak about today. So these are very large scale and very well-powered cohorts that often capture health and biomedical information on several hundreds of thousands of individuals, often have healthcare or registered data that are capturing really a lot of health interactions of individuals from cradle to grave. They have some clear downsides when you compare them to disease-specific cohorts. For example, they capture fairly noisy real-world data. They have not the depth of information for distinct disease. So Richard said that it would be difficult to grade the progression of Parkinson's, for example, with scaled systems, but often we don't even have the information that would be required to really come close to using that sort of markers that are being used in clinical trials in those biobank resources. Often we do not have at all specific longitudinal measurements. But nevertheless, these data sets are extremely powerful, and this is just by the scale of those hundreds of thousands of individuals who participate. Next slide, please. Because what allows us, these numbers allow us to do with these cohorts as we conduct what we call all-by-all JIVAs, where we can link genetic information that we obtain in those cohorts to the very comprehensive phenotypes that are not just limited to one single disease, but maybe really thousands of health data points in those individuals. And very recently, we have added to this component really also omics data sets where large-scale intermediate markers like a transcriptome or a proteome parameters are being profiled from diverse tissues that are that enable us really to overlay this with a genetic and the clinical outcome information. And what we do with those data, because genetics for us as biased geneticists is really a fairly solid ground, is that we conduct phenome-wide association studies. So we use the genetic variation to simulate the impact of a drug on a distinct gene or a gene product. And we conduct association study between variants in this gene and the outcome measures of interest to us. So for example, a phenotype 1, where if we find an association that might protect from that phenotype, we may get a support for efficacy for a drug. Or there's, of course, other phenotypes because we're not selecting only one, but really multiple ones. We get support that a drug that we would be designing against a distinct target is also efficacious for other indications. Or just the inverse, because we may find associations in opposite direction. Instead of a protective effect, we have a disease risk increasing effect. There might be suggestions or indications for adverse events. And all this information really can be utilized to predict the efficacy and the safety of drug targets really at a very early start. And the next slide, please, just goes a bit into the details of what we do in human genetics to really refine our information and come closer to a drug. I think you can click twice and you will see the full slide, or 3 times you can see the full slide. And I may not want to go into detail here a lot. It's a bit difficult without seeing the slide. But just on the right side, that's a couple of activities that we where we have been collaborating with Chris and team to come up with new tools, how we can really improve our confidence that a gene is indeed related to a certain gene function, and that it is indeed the causal gene, and the directionality of our drug hypothesis lines up with the genetic effect. Next slide, please, slide 7. What I do want to spend a bit of time on is now the exact vignettes. So the 2 databases that we have been using most, and you can immediately click again. All of you probably are very well aware of the UK Biobank, which is probably the largest repository of its kind, where more than 500,000 individuals have been recruited during the years 2006 to 2010. And meanwhile, we have sometimes close to 30 years of longitudinal follow-up information of those. Biogen was part of a consortium where we have generated very detailed sequencing data, whole exome sequencing data, on nearly all of those participants. These data are freely available, and we have generated resources that allow us now to link those genetic data to a very comprehensive set of phenotype information. And this data is all public. There's other consortia and initiatives that are really constantly maturing the wealth of information that is accessible through UK Biobank. Next slide. Similar to UK Biobank, we have been among the drivers of FinGen, which is a resource that has now reached about a similar size as UK Biobank. This is now a research effort that is coming to place by about 13 pharma companies teaming up. Helping to generate such resources is extremely expensive. Typically, these activities happen all in the pre-competitive space. So these different funders are really working together, and in this case with 9 national biobanks across Finland, in an initiative that is supported by the University of Helsinki and coordinated through the Finnish Institute of Molecular Medicine, primarily Arno Palotti and Mark Deli, and is really aiming to establish a similarly cutting-edge resource as UK Biobank in a way that allows really to very securely access individual level data and utilize these information where genetics is linked to a detailed individual scale healthcare information to the scientific interests of a really large spectrum of users. Next slide. And the reason why we moved to Finland is that Finns not only have a very good healthcare system with digitalized health records that longitudinally capture really a large amount of healthcare information, but also because they distinguish themselves through unique genetics, where Finnish population has undergone several bottlenecks in their evolutionary history or settlement history of Finland, which has led that certain genetic variants in Finns are showing up much more frequently than in non-Finnish individuals. And this has also led to the opportunity in a way to conduct genetic association testing on such variants and find a significant new genetic associations at much lower sample sizes than we would have to do or generate data on if we would go to other populations. So I don't know where you are currently at the slide, but you can really click towards the end here. We have the ability to link really this now very detailed genetic data to the very detailed healthcare data in these phenome-wide association studies. And if we go on to slide 10, then and you can also click twice here. What I would want to briefly tell you about is the collaboration that we had with Chris, Zhana, and team, where we conducted a meta-analysis, so a joint analysis of UK Biobank and FinGen, so both resources that I just talked about, where we conducted an association testing in more than 650,000 individuals, particularly for coding variants. That means those variants that impact the protein coding parts of the human genome. We try to overlay close to 800 disease endpoints between those two data sets. That's shown on the right side, that in principle, these data points and disease endpoints match quite well between those two resources. But I really have to tell you, if you're asking for utilization of AI in healthcare, making matches between phenotypes across such type of resources is really a huge opportunity. And I'm very sure with large language processing models, this is where we will be able to much outscale what we are currently doing. In our case, it was really two MDs sitting together and trying to make these matches fairly manually. But in general, we have a very large and well-curated set of diseases. We have a large number of individuals, and we have relatively rare variants that allowed us to conduct a thorough association study. And this is shown on slide 11. I don't want to go into any details for that study, but what we did find is really many novel genetic variants, particularly now at a minor allele frequency of less than 2 in 100 individuals. That means really at the fairly low end of the genetic variant spectrum, at an area where before these type of data sets have become available, there was no association testing possible. And this is particularly important because it now leads us directly to the most likely causal genes. And instead of having to do a lot of laborious downstream analysis, we can typically be quite confident that the gene that we are hitting with those associations is really the one that we then should also follow on for our drug discovery efforts. Next slide. The part that I would like to highlight, where our bioXcelerate colleagues have been particularly involved in, is that we were asking, well, we are now going into those fins with the assumption that we indeed need much lower numbers for increasing association power. Is this actually true? And can you make us predictions that our bet on Finland as an investment area really has paid off? And this is in fact what beautifully came out and was validated in a simulation effort that we did together with bioXcelerate, where we could indeed see that the enrichment of genetic variants in this Finnish population has been a massive driver of the association signals. And for, I think if you look on average, we probably would have needed for many of those signals about 10 times the size of the population in UK Biobank if we for coming up with similar association signals. And what was also really important to find was that the rarer a variant and the more enriched a variant was in fins, the stronger was indeed the association power. That means the return on our investment. And this is really a strong argument that future such endeavors should indeed focus on populations where variants are enriched, similar like in Finland. And this brings me to slide 13, where I wanted to highlight that these meta-analyses, as we are doing, have been doing between FinGen and UK Biobank, are going to become really more and more important, as has already been demonstrated in the GBAS area, where people were looking at a single trait. And this slide just shows an example where our colleagues conducted an association testing for schizophrenia, where they combined European data sets with data sets from East Asians. So two larger scale jivas that just by putting together two different individuals from two different geographies have led to a massive increase in the associated loci, and with this the starting material for us to find new drug targets. And if you click once, you should see that one of our main questions is, so if we see that sort of examples, what are actually the cohorts that pharma partners should best invest to gain a maximal scientific insight? And because there's so many opportunities in principle, some tools are really helpful or could be helpful to make and help us prioritize. Next slide. And this is exactly where, again, we teamed up with Chris and team, where we thought of, can we actually use the available data to entirely reinvent how we conduct genome-wide association studies that in the past have really required a very thorough curation of individual level data and fairly laborious analysis of and quality control of those data, which had to happen at an individual level and then required an enormous compute time to conduct results and gain results even for a single trade, let alone thousands at once. And next click, and this is where the idea of in silico jivas came up, where in principle we felt like, well, instead of going for many individuals all one by one, we could just utilize the bioXcelerate tools to define an default or average individual that would allow us to really then predict the outcome of genome-wide associations by just utilizing 4 parameters, essentially information on the overall cohort size with a number of cases and the number of controls, as well as the frequency of the variants that we would want to study in cases and controls. And this is now really a really exciting tool, as you can see from slide 15. The next one, where as one feature, we can utilize leapfrog sampling to extrapolate variant association cells in hypothetical cohorts. So instead of really doing this laborious effort, going to find people who are willing to donate a blood sample as well as their biomedical data, and then conduct very laborious and costly genotyping and association testing, we can essentially just make predictions of, well, if we would do this in this cohort, what would actually be the outcome? And indeed, we just hypothetically generated virtually in large cohorts and tested if we would use this ISGVAS approach to predict what would be the outcomes, how good would that be? And as you see in this graph on the left is that we really successfully applied this, for example, at the case of schizophrenia, again, where we compared where we would have ended up if a GWAS that we did in 2014 would have been extrapolated by ISGWAS to the GWAS that was now coming out in 2022. And you could see that just this in silico approach from bioXcelerate would have predicted 75% of the new association signals that have coming up, and only about a quarter of them were either subsignificant or incorrectly predicted. So overall, I think this is still a click. Tools like this ISGWAS may indeed guide investment decisions into future biobank projects. And with this, I'm at the end of my presentation. Thank you very much for your attendance and for listening. And I hope it somehow worked out also with the slides. Thanks very much.
Perfect. 1, 2, 1, 2. Perfect. Perfect. Thank you, Heiko. And yes, I can confirm it worked perfectly. Sorry for making it a bit extra difficult for you. We had to test you. Finally, for our last talk of the day before we have a break, You've heard and seen, I think, Ricardo's name mentioned in different slides also. We have Professor Riccardo Marioni, Chair of Molecular Epidemiology of Aging at the University of Edinburgh, a very close partner, collaborator of the bioXcelerate team, and he's going to speak exactly about that. The topic is partnering with bioXcelerate to accelerate genomic research, a view from academia. His passion lies in the exploration of aging, with a particular focus on unraveling the genetic and environmental factors contributing to health, cognitive aging, and dementia. In recent years, his research has focused on DNA methylation, investigating its role in gene regulation and its interaction with genetics, lifestyle, and environmental factors. Ricardo and his group specialize in integrating multiple omics datasets, including genetics, epigenetics, and proteomics, to deepen our understanding of dementia's molecular underpinnings and refine risk prediction. Ricardo, all to you.
Thank you so much, Harry. So today I'm going to give a very brief overview of kind of our perspective from academia on working with bioXcelerate and what advantages and benefits we can have from these partnerships. So as Harry mentioned, I'm Professor of Molecular Epidemiology of Aging at Edinburgh Uni. So molecular, meaning genetic, proteomic, epigenetic types of data. Epidemiology, meaning large cohort studies like the biobanks we've already heard about. Aging is a slightly more challenging term to define, whether that's purely as chronological aging and the passing of time. How does that in turn relate to biological aging, so the aging in our cells, organs, and so on? And then what about healthy aging? How do we go about defining that? Is it absence of disease? Is it subjective well-being? Lots of questions about what is aging and how we should define it. So on the next slide, I'm going to show you a fairly graphic illustration of aging. I'll let you decide whether it's chronological aging, healthy aging, or biological aging, but please keep your answers to yourselves. So this is my profile through science. So started as an undergrad in maths and stats at Aberdeen Uni, came down to Edinburgh to do an MSc in operational research, then a PhD in genetic epidemiology, followed that with a postdoc fellowship in Cambridge in biostats and epidemiology. Was lucky enough to spend some time in Bordeaux as part of that fellowship, then back to Cambridge, then back to Edinburgh on a tenure track position, which also gave me an opportunity to spend time in Peter Vischer's lab at the University of Queensland, and now back in Edinburgh as a tenure track professor. So I think there's a few kind of pretty striking observations in terms of aging here. You can see that I've clearly lost my hair, lost my eyesight, and interestingly, the only time I seemed to be able to smile was actually during PhD and postdoc times when I was doing data analysis all the time. Read into that what you will. But in terms of aging, how we measure it and how we relate that to healthy aging and disease risk, that's really what motivates our group. So in the cartoon here, we have very, very simplified overview of our work. So we're interested in collecting biological data, biosamples, whether that's blood, saliva, urine. We also like to measure phenotypes, whether that's things about the here and now, so lifestyle factors, or things in the past, things in the future, so disease risk through linkage, brain imaging. And then we try and use statistical and machine learning approaches in the middle to identify patterns from the biosamples that associate with these disease outcomes. And to break this down even more simply, we have lots of data in terms of what we collect, and in the middle we have methods. And I think this is a space where bioXcelerate, from the previous talks and from our experience of working with them, they're really thriving and creating some fantastic tools for the genetic epidemiology cohort and for biomedicine. So one of the cohorts that I work with, and we've worked with bioXcelerate on as well, is called Generation Scotland. This is a study that began in 2006. We recruited around 25,000 individuals to the study from 5,500 different families across Scotland, so up to 4 generations per family. Interestingly, we have data linkage to health records on almost everyone in the cohort. We've genotyped over 80% of the population and about the same number with DNA methylation. So back in 2006, when the cohort began, we invited individuals to attend a baseline clinic where there were hundreds of questions, so kind of pen and paper questionnaires. There were also clinical measures were ascertained, so things like cholesterol, lipids. In terms of the questionnaires, things about lifestyle, so alcohol, diet, feedback on pain, other diseases, more medical tests as well, so things like lung function, and also cognitive testing, depression questionnaires, all sorts of data were collected. In addition to that, we had the blood samples that I previously mentioned. Linkage I'll go into in a bit more detail on the next slide, but crucially for the cohort as well, we also, our volunteers very kindly agreed, or the vast majority agreed for us to potentially recontact them in the future. So this could be things like recontact by genotype. So say if there's a rare variant or common variant in the population, and we want to identify individuals that carry that variant, whether that's for inclusion in clinical trials or to test out or to follow up for whatever reason it might be, we can recontact those individuals and ask if they'd be willing to join studies. So this is studies that could be led by research, by industry, by pharma. GS is open to working with all partners for biomedical research. We could also look to recontact individuals with a specific disease. That could be based on the self-reported data at the start of the study, or it could be based on data linkage. So here we have good linkage going back to around 1980 for a whole host of modalities, so GP data, hospital data, clinical biochemistry and lab tests, prescription data. So it's easy to identify individuals who had diseases before they joined the study and those who went on to develop diseases after they joined and donated samples, biosamples for us to analyze. The numbers on the right-hand side of the slide here are quite out of date in that we have many million more records than this now available. So from a data science perspective, this includes things like images as well, and also a lot of potential for text mining and written records. So we have lots of great data. We have lots of great data scientists as well at the university. So why collaborate with bioXcelerate? This is the main reason. Maybe 30 years ago, Wingdings would have been a mildly amusing font. Does anyone want to have a guess at what that says? Anyone fluent in Wingdings? No? Translation. So I'm quite aware that in academia, very often, when writing grant applications, when writing papers, when communicating our science, if we're identifying potential biomarkers or from GWAS studies, we have genes or genetic variants that we think are of interest and could be clinically relevant. Yeah, we might write these things in our introductions and our discussions and our grant applications, but how realistic is that? And I think only really by working with industry partners, with the likes of bioXcelerate, biotech, and pharma, can we really start to drive questions where we can have a genuine chance at translating findings into clinical practice. So this is highlighted quite nicely in this entertaining and somewhat provocative paper published last month. So switching around the phrase of all models are wrong but some are useful to all models are wrong and yours are useless. Kind of a summary of some of the limitations that are present in a lot of these kind of biomarker and kind of drug target studies that we might produce in academia, and really challenging us to think, how can we make these models more clinically relevant, whether for the likes of the NHS or for drug discovery within pharma. So some examples here of ongoing collaborations between my group at Edinburgh and Optima and bioXcelerate. So the individuals shown here are Rob, who is a postdoc in my group. He's a background in biomedical science. Danny, who has a background in neuroscience and was a PhD student. Scott, who's an Optima employee and now also a part-time PhD student on the university's Biomedical AI PhD program. And then on the right-hand side, Daniel McCartney, who's a senior postdoc in the group and also a part-time employee of bioXcelerate. And his background is in genetics. So quite a broad background from our group, from bioXcelerate as well. And we collaborated with Chris, Zhana, Heiko, and Ben, who have already been mentioned, on a couple of recent preprints, which hopefully will be out fairly soon as publications, using the proteomic data from UK Biobank. And this was to, for Rob's paper, it was to explore the genetic contributions to not just differences in protein levels, but also the variability in protein levels. And with Danny's work, it was asking, do protein levels at the time of the biosampling in UK Biobank, do they associate with disease outcomes 5, 10, 15 years in the future? So whilst I think the work there is really exciting, one of the limitations around Danny's project is that it's perhaps a little bit naive to look at a blood sample at one point in time and then just a solitary disease outcome in the future, 10, 15 years in the future. Because this is, or at least when we ran these analyses, it was without considering what diseases had occurred prior to that time point and what diseases had occurred in between that time point and the diagnosis of the focal disease. So Scott did an absolutely incredible job in his MSc project that he did with us last summer. This was taking advantage of the data linkage in Generation Scotland to the primary and secondary care records that we have from 1980 through to present day. And here he was asking, or building a visualization framework to look at diseases that co-occur and to look at trajectories and pathways that occur prior to a focal disease endpoint. Or flipping that round, after being diagnosed with a disease, what other diseases is one more likely to go on and develop? So in the example here, we have stroke on the right-hand side as the terminal node. And one thing that's perhaps a little obvious and we're currently working to tweak is you can see that ischemic heart disease, osteoarthritis, and a few other diseases frequently pop up in these pathways. So these are basically diseases that are very commonly diagnosed in older individuals. So what we're now trying to understand is whether these diseases or these transitions are occurring more frequently for those who go on to develop a stroke compared to the rest of the population. So looking for enrichment of the pathways rather than just modeling the observed numbers across each transitions on the branches here. And I think this could be a really useful tool when scaled up to biobanks. So it's nice that we've piloted this in Generation Scotland. We're now extending it to UK Biobank. And there we can ask, of the enriched pathways, are there any genetic differences across those paths? We can use tools like in silico GWAS that Heiko mentioned to run really quick screening analyses of these different pathways, analyses that would take quite a long time using off-the-shelf methods. And then we can ask, are there differences in polygenic score by the different trajectories? And by integrating things like the prescription data, does this tell us anything about who's more likely to respond to drugs, and so on and so forth? So, kind of approaching the end, but just to say that Generation Scotland, while we have 25,000 individuals in the cohort at the moment, we're currently recruiting new volunteers, so from age 12 and above, anyone that's living in Scotland, regardless of where you were born, is very welcome to join. It's a quick online questionnaire. We then send you a spit kit in the post. So instead of individuals dropping into a clinic for hours of tests, this is now a very quick process and convenient. So spit in a tube, post that back to us. We extract the DNA for genotyping and methylation analyses. We also ask if people are kind enough to agree to letting us link to their medical health records, and also for the potential to be recontacted. So again, trying to build up this base of individuals that could be useful for future studies, whether academic or industry-based. So in terms of the next steps, as far as I see them from my viewpoint in academia, bioXcelerate is developing cutting-edge tools for data science. Of course, we want to be able to access and to be kind of first users of these tools, to apply them to our innovative data sets, and also to work with bioXcelerate and their other partners, so pharma, biotech, and to do this to really kind of co-develop health research projects that have a genuine chance of having an impact in terms of translation, whether that's at the healthcare setting or at the drug development setting. And with that, just to thank everybody in my group, thank you to all of the Generation Scotland volunteers and research team, and thank you all for listening.
Thank you, Ricardo, and a big thank you to all the speakers for the day, if we can. So we've reached the end of the first half of the event. We now have 20 minutes where we can grab refreshments, stretch our legs, and for those live, we'll see you back in 20 minutes.
Recording in progress.
I'm going to a random crap festival thing.
Your graph now because Biogen did column class.
Yeah, it's great as well for the
Hello?
likes of the
Hello?
Biomed AI
Yeah.
students. And
Am I? Okay. Hello? Okay, bro. Hi, everyone. We're just going to get back together, reconvene for the Q&A. Oh.
Can you? Maybe do your mic. No, just.
Thanks.
Okay, I think. No, I think we're still fine. Okay, no, they're not. You need.
Hi, Zhana. Do you want to take a seat? And Ricardo. Aha. Bro. Richard. Let me prize you away from a very interesting conversation, no doubt. Okay, while Richard is popping his mic on and settling down onto the couch, we have two new members of today's operation in the form of Paul Agapau and Manju Dissanayake. And both are experts in data. Paul has a deep and rich expertise in computational biology, has worked with major pharma, runs a very, very popular data collective in London, of which he has been very generous, inviting some of the bioXcelerate staff to present. Manju is also a wonderful data expert. He is an innovator at bioXcelerate and has driven forward many of our products. So, Paul, I don't know if you've got a couple of words just to introduce yourself, and then we'll do Manju. So.
Absolutely. I feel like a ground pretender because originally I was an immunologist until computers happened to me, like they do with many. And ever since then, I feel I've been the person in the middle to make sure that we get the informatics and the computation and everything we need in order to understand biology. And that context that comes from biology is provided towards the informaticians and the number end of things. As said, at GSK, at AstraZeneca, and many, many years, perhaps unfortunately, at the university, including Imperial College. So thank you.
Thanks, Paul. Manju.
Hi, I'm Manju. Like him, I started life as a biologist, medical microbiologist at the University of Edinburgh. And I've always been interested in computer science, so I've gone over to machine learning and AI, specializing in evolutionary algorithms, doing optimization, doing evolutionary algorithms. And I do have experience in engineering as well. So I kind of, in bioXcelerate team, I combine computer science, biology, and operations as well.
Bro, we also have Benjamin Sun online, who is an incredibly accomplished scientist. He's a medical doctor, PhD in statistical genetics epidemiology also, and has a solid track record. Ben, I'm not sure if we have, and Heiko is also online. Ben, I'm not sure if we have, oh, hello, Heiko, we can see you, amazing.
Yes,
wonderful.
Apologies for the technical issues before. So very nice to meet everyone.
Bro, Ben, do you want to do a little
Yes. I think you've done most of the introductions there, Chris. Yes, I sort of started off from life as a medic and then ended up sort of venturing into sort of the research side using, when biobanks and large-scale genomic approaches were just beginning to take off, along with other multi-omic approaches like, proteomics and metabolomics. So worked in that field and then sort of moved also to sort of into industry, where sort of translating the science sort of into more of an industry framework, and sort of have been straddling between sort of the three pillars ever since. And it's kind of see there's, opportunities and challenges that, this initiative would likely benefit.
Bro, thank you so much, Ben. I mean, Ben is joining us from Boston. Unfortunately, the time difference did not favor him to do a day trip. And Heiko is currently in Germany, in Heidelberg. So thank you very much for both for dialing in. Okay, so I'm going to get the ball rolling, and my apologies for the facsimile on the agenda. So basically the theme, which Richard mentioned in his presentation, is how healthcare organizations, pharma, charity, NHS can utilize AI and ML products to accelerate and increase the efficiency of drug discovery and development so that patients can get efficacious treatments more quickly and at lower cost. Okay, so that's the theme that we're going to sort of resonate around. But I'm going to start with asking about clinical outcomes. So data has absolutely transformed how we approach science. So in terms of the volume of data that are available and the ability to capture dynamics of a physical system hidden in there. And no more so in the last 5 to 10 years. So this is pretty fresh. And my understanding is that, we still need solid use cases to prove out some of the technologies and their efficacy. So I'm going to start with what clinical outcomes might we consider to first prove and develop the value of AI-derived insights. So those that target most prevalent diseases or improving quality of years. Paul, please.
Yeah, you can see I'm begging to reply to this. So let me subvert that question a little bit to start with, and it's to emphasize that in fact it is a very sensible question, and in fact it is the core one that we need to answer here. What are the clinical outcomes in any of this that we do? Because historically, of course, we have gone in medicine from the traditional, what we call modern medicine, where we have a set of established practices that we believe actually benefit the patient and so forth, to the advent of evidence-based medicine, which at first seems ridiculous and absurd, but the very fact that what's the evidence for any of our treatments actually providing a benefit to the patient, and that approach has actually sometimes given us some very uncomfortable findings at times. That if we treat people for fevers with antibiotics and so forth, that actually their illness will last 4 hours less, say, or that even there are treatments we found that when we use them, that the outcomes were worse. So we do definitely need to start talking about this. What is the bottom line? What's the outcome here, okay, for the patient? The second half of that is why it's also very necessary for these approaches. Because we live in an age of wonders where all of our AI and large language model pixie dust solve all our problems immediately, and we are moving into nirvana where everything is done and none of us will need to know skills or anything like that. But the vast majority of these systems fail when they try to put them into the actual clinic. You can look, there's a number of papers there. There's papers about AI models during the pandemic. There's a series of papers by Laura Wyse and so forth that showed that if you got all of these models that were published in the literature, the vast overwhelming majority of them were useless. They could not be applied for actual patient outcomes. Now, having set that up, I'll just very briefly talk about what is it we should measure. And I think we should very much look at patient-centric measures in there. There are things that are easy for us to measure, but they're not necessarily the things that patients are interested in, things they're good for. For example, if you're looking at cancer therapies, the gold standard is overall survival, how long we live. Except this, of course, it's a fairly brutal thing to measure. It's sometimes very difficult to measure. And often for a patient, the thing that actually matters is how long am I going to be disease-free? What's my quality of life going to be? So we need to measure things like time to next therapy, or how long do you have off the cancer carousel before you go on to your next treatment? And I'll stop there.
Thanks very much, Paul. That's very insightful. I think we often always, we think in terms of the disease endpoint and reducing risk, and maybe not some practical elements within that as well. I wonder if anyone else would like to jump in. Richard, you look like maybe you have, we understand your neurogen focus in Parkinson's, but clinical outcomes.
So I'm really envious of people working in oncology. Obviously, alive and dead is pretty clear as an outcome, but also you can measure the size of a growing tumor. It's 1 millimeter, it's 2, it's 3, it's 4, and you've got some very, very hard measures, and I'm terribly jealous of that. I mean, I've complained about the outcomes measures we use that are based on scales of 1 to 5, an opinion of a neurologist that does it depend on whether they had a bad day yesterday? It's something out of the medical history books, and we're trying very hard to change that.
I think this is a really important point, and one that maybe is difficult to translate into the public sphere, which is we think that AI can ingest all types of information, as Paul has alluded to, and suddenly invert. Apologies, I will do a little small dance in order to find a spot of low resonance.
I had to do that.
So the AI will invert some of the difficulties in terms of designing the data, and it simply won't. It ingests those difficulties and maybe reinforces them. And I think one of the demystification, we often talk about the demystification of the algorithms, but actually it's about the measurement process in clinical outcomes as well. And I think that's news to a lot, that, for instance, in cancer and in cardiovascular disease areas, we have quantitative measures that we measure through medical devices, etc., whereas there can be very informed, but nevertheless opinion-based measures that we use in neurodegenerative disease. Ricardo, you look like you want to come in.
Yes. So I think just to double down on that point, where in terms of neuro, if you look at the various subtypes of dementia and how you can see with the gold standard pathology how some post-mortem brains will be heavily loaded with pathology, yet the individual would have had no kind of clinical manifestation of the disease, yet others. So there's kind of this compensation thing that some people are better able to cope with the disease pathology. But I wonder if we can maybe use biomarkers, omics, and AI to come up with data-driven characterizations and subgroups of disease. So you can identify those that are more likely to be, or might be less likely to be affected, and are there, whether it's polygenic scores or other characteristics that define subgroups that may respond better or worse to different treatments.
Well, that takes us quite nicely on to the next question, but I will offer the opportunity for our esteemed online guests to maybe give their input there, given that they're both medical doctors as well.
I guess my addition to this is mostly sometimes it's about the model that's been trained and the models that's available to the data that's been fitted. So obviously, in some diseases, the more prevalent ones are more likely, to benefit from these data-hungry models than something that's rare, where you just don't have the data there. And obviously, that goes down the stream of what data should we be collecting, and AI and machine learning, algorithm can also guide that in terms of these should be additional data we should be collecting to reinforce certain disease areas that are low prevalence. I guess the other part is really is not about sort of necessarily sort of replacing, the clinical outcomes that are here, or how a clinician does their sort of clinical workup. It's more at the moment. It's more about sort of using it as a guide, as a co-pilot, to suggest, and so you're not missing the important things as a reminder. And also the modality, I guess, is the other thing. AI, imaging itself is probably more mature in the AI space compared to some of the other sort of AI models. And obviously, the different modalities have progressed at different rates. And so sometimes, you can have, radiological endoscopy live sort of aids that are driven by AI to help you, for example, pick up cancerous regions on, slides, as a pathology slides, or radiology, or, in an endoscopy setting. Whilst, others, like medical text at the moment is still a challenge because there's a lot of individual variation of how the text is inputted. There's a lot of errors, there's a lot of noise, there's a lot of habits that different clinicians take on. So there's still a lot of challenges there that still need to be worked out despite the emergence of these language models.
So what I hear there, Ben, is that there is lots of proof of concepts that are there to augment already established processes, but we're still working towards that great big leap that we can achieve. Although there may be some sizable steps that we've taken to date. Bro, Heiko, I can bring you into another question if you would prefer. So. The nice transition from Ben Ricardo there was to think about geographical considerations. Now that's something that Heiko had in his talk, Richard had in his talk as well, and Ricardo obviously was speaking a lot about Generation Scotland and the nuances of the Scottish population as well. So in that vein, how might we consider geographical differences in disease prevalence and characteristics as presentation in order to prove value in achieving fairness? So one thing that often is talked about with machine-driven learning is about, reinforcing bias in data sets, reinforcing already overly represented demographics in populations. So what can we do there in terms of geographical differences? I wonder who wants to put their hand up there.
Well, what we're doing is, I mentioned it briefly earlier, but we've now got over 200 genes which influence your likelihood of getting the disease. And in our GP2 program, we've got 400 PD geneticists working in 80 countries, because the genetics do differ from country to country. And I don't know about, well, I'm pretty sure that's true of a lot of other diseases as well. But I think Parkinson's has bitten the bullet, and we've recently reported 3 weeks ago, I think, a new gene in Parkinson's related gene in Africa. And these are popping up all the time now in Japan, in China. You don't get that gene, but this gene gives you Parkinson's, with some sort of autosomal recessive component or whatever. So we're learning all the time, but we cannot do this in a Caucasian population and think we're representing the world.
Can I bring in Heiko here? Heiko, I wonder if we just do a mic check.
So I think you mentioned the biases that come from the different geographic regions, but I think that's already one of those opportunities that you do find systematic ways to actually work out those biases using AI. Or I immediately think of phenotype imputation, what I also referred to in my talk, where we can just use hopefully, maybe existing or improved large language models to work out where do we have missingness of data, how can we eventually infer phenotypes or intermediate endpoints from typically sparse data. And so that if we can really apply that approach to these very large cohorts, we would already gain quite a bit and could do a more refined association testing than to the relatively crude endpoints that we are currently applying to. And if we would be able to do this really not cohort by cohort in a very much handy manner, but systematically across many of those, I think this would very much accelerate our way towards conclusions. So I see it in a way as an opportunity currently. And yes, in terms of equal access and the opportunities to really deploy tools in different geographies or ethnicities. I mean, that's something we as geneticists are working through since very long, where we have our entire field focused on Europeans, and this field is only catching up now very, very actively, in fact, in non-European cohorts, after it not only has been recognized, this is underserved ethnicities where we have some obligation to go, but also because we see, there's enormous discoveries to be made and enormous opportunities for actually utilizing those insights.
Absolutely. Every challenge is an opportunity and opens a new door, isn't it? And I think this is something that's known in the wider large language model community, and maybe I'll bring in a little bit of Manju's time here. First of all, the enormity of the data estate that the large language models are trained on give us our first step forward. But of course, they're not necessarily automatically appropriate for the challenge at hand, and therefore we have mechanisms to repurpose and repoint. So if we have gold standard scenarios where we have better phenotypic labeling or understanding, then we can use architectures, which, not to introduce too many technical terms, but retrieval augmented generation in the large language model space that allow us to repurpose. Manju, I don't know if you want to say something about that, the sort of pre-trained versus better using gold standard data to funnel that towards more appropriate.
What I'd like to add to this discussion is about deployment of these pre-trained versus your classic tools or your bespoke tools. Deployment is going to be quite difficult to do without bias because of GDPR and data residency rules. Because, for example, some countries in the world have this rule that says their data cannot leave their jurisdiction. So if you are going to be doing a study that spans multiple countries, you need to take those issues into consideration. So whether you're deploying an LLM or a bespoke tool, you need to take that into consideration and design your solution, your study to match those conditions.
I really like that, and a shameless plug, a nod to Heiko's mention of in silico GWAS, which does exactly that, right? By summarizing and effectively anonymizing the data per region, you can still aggregate as if you had access to each of the individual level data. And I think that is, that's really about the design, the challenge, and the ambition to meet that challenge. Shall I move on? So, once a successful AI and ML-driven approach to drug discovery has been identified, what are the challenges in scaling these solutions? So, Ben, you mentioned that there are some exercises and scenarios where we've had success. So, how do we scale these solutions? And I guess I can add a little bit more meat on the bone there and talk about things about reducing time and costs associated with bringing new drugs to the market. Again, all links to what are the successes to date. So scalable solutions is the key. Zhana, can I introduce you to that one?
Yes, of course. So one of the challenges I see is access to data. So scaling solutions means you want to do it either across different types of data sets and settings, or you want to do it more and bigger and faster. So if you want to do it more and bigger and faster, obviously depending on what institution you are in and what type of access you have to data, that might be very easy for you, or it might be very challenging, as smaller companies and biotechs and even charity organizations don't have access, or they don't have access to large computational resources. They don't have access to engineers to set up this overly complicated, not overly complicated, but complicated cloud architectures that enable this type of scaling up. What Richard said about open access data is incredibly important, because it will benefit the rest of the world beyond just large organizations and institutions to be able to try and add value. About scaling these AI solutions across data sets and across different, not industries, but settings, we're entering in what you also said before that about biasing AI. Data is not collected in the same way. We don't have the same data protocols about collecting data, even with the same diseases. What Richard didn't say about Parkinson's is that those ranges and those scales, they also different between countries sometimes, or between academic institutions, some of them, or the way they define them. And that's true for many other diseases which in neurodegeneration and also in cognitive diseases, or even talking about mental health issues. So not being able to have the same scalable, comparable data and the same data collection protocols across different settings, countries, data sets, so that you can make, so that you can introduce those to the AI models without any bias, is just going to lead to a lot of garbage in, garbage out situations.
I think that's incredibly powerful, that actually it's about data harmonization of protocols, and in fact, in clinical research and with the principled application of statistics and data science, we often look first at harmonization and standardization of protocols. So even to the biobanks, the way in which we're enrolling participants, classifying disease status and common across different centres, etc. I think absolutely. So first, what I hear is first we should think really carefully about the data design and protocol. Paul, as someone who is sat at the heart of innovation, I wonder if you've got a couple of words on this as well.
I do a little. I feel like I could almost summarize it up by saying, it's hard. I think this comes back to the whole, we have a universe of proof of concepts out there. What is it that we can actually walk out and sort of distribute? And there are very much these real fears. I think that AI, in a sense, is a rich man's game. Who could ever afford the computation to put together something like ChatGPT and Llama and all of those sort of things and so forth? So there are a couple of different angles, I think, on this. Number one is that, and I mean, I'll boost you guys if you won't, things like in silico GWAS, I think, are incredibly important. How can we run computations in an effective, efficient way without needing to bankrupt ourselves? So forth. The second thing I think is is to echo this about the harmonization efforts for data. Now, this used to be a really fraught problem. I should say I once worked on an observational trial where the white blood cell content was measured in 3 different ways across the countries that we're looking at 3 entirely incompatible ways. But nowadays we have things like OMOP, okay? We have data standards that we can use to make these things comparable. And I think the next step is going to be building that suite and that galaxy of tools that can speak those formats, speak those languages, and help us get data into that format. It comes back to that old joke about AI or data science sometimes that, when people get interested in a subject, first they think that they're going to need a big computer, and next they think they're going to need a bunch of brilliant data scientists, and they finally conclude that what they actually need is data. We need to sort out the data problem or everything else is moot.
Completely. Colleagues in engineering couldn't agree more, and I'll speak on their behalf. Richard, please.
Yeah, I want to respond to something Zhana said, but also something you said. So I've tried to make sure that all the neurologists, Parkinson's neurologists that are in the trials that I've launched, and there are a lot of them, a lot of trials, a lot of neurologists, that they've all trained in the UK or Harvard or in America somewhere. And that means that the delivery of the understanding of the rating scales, however bad it is actually applied the same way. But here's me in 2020 or 2019, I'm in Beijing. They've got 3 million Parkinson's patients there, overwhelmingly more than any other country. And I'm planning to launch 5 trials there with one of the leading PD neurologists in China. I'm breaking the rule because of having them all trained. He was trained, he worked for 11 years at Harvard before he went back to China, but he's kind of running the show there. And there's 1,000 neurologists in China, and they handle the 3 million Parkinson's patients. And everybody is linked to each other by WeChat. It's an astonishing network. And we were seeing what we could do. You need about 4 hours to measure all the rating scales of a patient if you've got them on a trial. But could we shorten this? How could we harmonize that? And the plans were starting to get advanced. And then this game of Parkinson's, well, China scored an own goal. Wuhan scored an own goal. And we couldn't start because of COVID. And we still haven't started, but this leading PD neurologist in China, we're meeting in Boston in 6 weeks' time, and we're going to try to relaunch that. But part of why I'm saying this is that I think that works for every therapeutic area. Mm-hmm. All patients are linked to all the neurologists in China via WeChat, and you can assimilate information by that network. If you need local Chinese people to facilitate it, because you need to know the infrastructure. But it's a fantastic resource that anyone in this room might want to consider.
I mean, that's an incredible resource of free text in order to effectively derive insights through free text mining, scraping, and depending on the kind of maximum sort of input allowable in terms of
and what count. The Chinese government will let you do. And we're not sure. We haven't put that to the test. But how much can you get out of the country? Yeah. But I would be very happy just to do it in China, and that's fine.
Absolutely. With three.
But I thought I should let everyone know that it exists, and someone's trying to prosecute it.
I just want to pick up on Paul's point about efficiency. I think that's a very important thing, because efficiency also drives equitableness across all the industry as well as academia. Because at the moment, you don't want the big tech to be the only ones being able to run these large models. And obviously, in order to, for everyone to be running it, you essentially need something that's highly efficient. And this could be coming through, computational methodology. type of things, all coming from basic, approximations from the ground up through mathematical means. I think obviously there's that disconnect at the moment because you have people who are working sort of the pure space where they do something and it works and then pop it on an archive and then no one takes it over until someone sort of spots it and then makes use of it down the line in an industry scale. And obviously there's a disconnect because things are done in a sort of academia way where you have breakthroughs in methodology doesn't necessarily lead to a computationally or industry grade tool that can be used. So there's always that disconnect. But obviously you really need that expertise to be able to sit on both sides and connect that up in order to make these efficiency gains. And that's how I think things like bioXcelerate is a very good idea in terms of being able to bridge that gap and having the expertise on both sides to be able to piece together what's really needed and how to actually realize that potential. And obviously, I think that goes on to, to say that currently a lot of things are just brute forcing it with better and better computers and hope things get faster and faster with faster storage and access. But obviously, these efficiency gains are going to be more and more important. Even with, large language models, people now go, let's go for a much smaller one, train a much smaller model and give them approximately good enough answer at a fraction of the cost and the computation. I think that's going to be more and more important as the data gets larger and larger.
Your prognostication powers are quite incredible, Ben, because the next question is about how important collaboration between healthcare organizations, technology companies, and academic institutions are in terms of advancing the use of these types of tools. So I think you set a fantastic basis. So I'll introduce one of our long-suffering academic colleagues in the form of Ricardo to maybe pick that up.
Yeah, I think Ben kind of summarized it perfectly, to be honest. And as I tried to allude to in my presentation, I think it's really important for us within academia to be open and to actively engage with industry, biotech, data science companies like bioXcelerate to really co-drive projects where instead of kind of the token sentence in a grant application or a paper, we're actually designing something that, sure, it may take 5 years or 10 years if it's a pharma-based or drug-based approach, but something that could actually have a chance of delivering. Because ultimately, we all have the same end goal. And I think it's fantastic that we have companies like bioXcelerate in Edinburgh, which is a massive data science hub to begin with. I mentioned the doctoral training program in biomedical AI, precision medicine, translational neuroscience. There's lots of areas of potential overlap, and I think kind of more academics talking to more industry and biotech is definitely the way forward.
Yeah, I mean, completely agree. I think the ability to contextualize the research towards the kind of practical outcomes that might be of relevance in industry and in commercial applications is so important, but at the same time to still maintain a sense of detachment that allows you to pursue avenues that you are interested in the pure scientific investigation sort of sense. And it's not that there is any one side or t'other. It's a very, very sort of difficult area to disentangle because there's rich science going on all over the place that's very pure in terms of its outcome to improve patients' lives across all communities. I like that. Manju.
Can I add something? Talking about scalability and collaboration, we sit in a perfect position because scalability in terms of data you spoke about, but scalability can be tackled from a systems point of view as well. So modern software is aimed for the cloud. They scale effortlessly. So you can run them at scale. It's not a problem. But our use case doesn't fit that scenario, that type of scaling. It doesn't fit. But what we bring is a bunch of engineers and software developers and experts who have expertise in traditional scaling. And now we are getting exposed to data science and health data science workloads, and we are learning how to scale them efficiently so that you can actually run these tools without going bankrupt or without having to own a huge HPC. So you can start small and then scale up and down as required, using all the experience that's available to us.
Bro, I mean, forgive me for, making an attempt to quote Winston Churchill earlier and now turning to Shakespeare, but it was ever thus, right? I think the point here is that, first and foremost, we are human, and there are human-level practical issues and collaboration constraints, etc., that surface. So they need to be solved initially, and sometimes that's about resource burden. So do we really want to be in a situation where the largest, in terms of financial footprint, organizations are the ones that can run these types of sophisticated analysis and therefore have first access to the sophisticated results, versus more of a diffuse approach? And I think, that's why it's really important to think, as Ben has said, as you've said, Manju, and as Ricardo has said as well, to think about, time to insight, what's a practical... So we often think of this trade-off between, if it takes me 100 days to achieve 95% accuracy versus 100 seconds to achieve 85% accuracy, where are you going to place, what are you going to invest in, assuming that they cost the same? Okay, so driving forward with this, and I really want to sort of bring in Heiko, Paul, and Zhana here, and thinking about, and if I start with Heiko, I'm thinking about how do we enable companies and organizations and society to become match fit, forgive my terrible terminology, to deploy these types of tools and win trust that we are improving lives and effectively prognosis for patients.
Well, that's a super hard question, I would say. I mean, you see that on the one hand, tools that are easy to use and clearly fit a niche like ChatGPT are being taken up at an incredible speed, and people use it for their purposes that are really being figured out on the fly. I mean, that's for private use, this is actually really amazing. When you let sort of the strings fairly loose, people come up with really creative ideas how to utilize such tools, and sometimes maybe I'm optimistic they will find great purposes that then also are sufficiently convincing on the go with 85% there of doing their optimal job of convincing broadly that this is the way one should go forward. I'm a much more on a much more skeptical note. I've the experiences from being an MD, working in a fairly structured clinical environment, being in clinical development, and that's the space that is really very highly regulated and super conservative in terms of following the right endpoints, making sure that we are really living up to gold standards, and fairly conservative in taking things that are just not 100% where we want them to be and where our patients expecting us them to be. And then really also in general a certain mindset that is really skeptical towards hype, and actually quite okay to take a couple of more years to work out a thorough endpoint instead of jumping on what seems obvious to an early researcher to jump on. So I think there's a lot of uphill battles to be fought, and especially from the company and the medical side, those parts that are the closest to regulators and the closest to patients. And here I think the field really needs to live up to these enormous expectations that are currently being put on it.
I couldn't agree more. Paul.
Well, I'm going to largely echo what Heiko said. Through a large part of my career, I was called a bioinformatician, I think because people didn't know what else to call me. And if you've lived in that milieu, you'll understand the completely Stygian quality of the software that you have to use. I think at one point when I was in Imperial, we formed a rule of thumb that if there was a paper that described a new piece of software, and the paper had dazzling benchmarks and showed that it worked perfectly and things like that, there was probably a less than 50% chance that it actually functioned. You know, it wouldn't run on your systems. You simply couldn't reproduce the results. They'd run it on some peculiar cohort. And this is very much in line with the work I mentioned earlier, Laura Winans. It's terrible. So my suggestion on one side is that we have to raise our state of that game in building software for biomedicine. At the current moment, it's an amateur's game. A lot of it is just people throwing things together, you know, that have never thought about software engineering or well-written program, things like that. And that's going to require efforts from funders, from journals and the universities, all of that. To take the far end of that question, so on the other hand, I think there has to be a lot of pressure and effort put into consortiums and pre-competitive efforts, okay? Because it's only through those that we can build things that we can put into common use across the industry that will raise all boats, if you will. No individual company or entity is going to do that on their own. They can't. Okay? We have to short-circuit this.
I mean, I really like that. Obviously, we have similar training, so there's going to be a bit of an echo chamber here. Zhana?
I'll bring in a slightly different point of view on the topic. Loved your answers, by the way. I think it's also about building trust between the AI community and the geneticists, biologists, and clinicians. Because sometimes we people, mathematicians, statisticians, forget that there is actual people staying on the other side of the line, people that every single day and every moment of their life are potentially suffering, struggling, whose lives depend on it. And Janssen had a fantastic example a while back when they trained the super high, ultra-modern AI neural network to predict some retinal disease. All their clinicians refused to use the results because they said, I'm not going to prescribe and something to a patient if you don't tell me which features exactly of the retina is this AI using to predict that they're going to have the disease or not. I'm not using it. So they spent another year retraining it using machine learning models that had interpretable parameters so that they could tell the clinicians which features exactly they're using to predict whether the patient's going to get the disease or not, because otherwise they're going to become blind if they get misdiagnosed. And we should always think about, we should maybe think less about our ROC curves and our accuracies and, you know, oh my God, I'm so much better than this other state of the class method, and think a little bit more about how do I explain this to the biologist or to the geneticist or to the clinician so that they can really use it to make an actionable decision on their patient's life.
I think trust is like a key word in there. Just like so much agree with that, because it runs like a golden thread through all this work. You know, I don't worry about the bus that I use to get here because I have trust that the bus will work, I understand it and so forth. But if you're going to put a black box in front of me and say, this will completely forecast what's going to happen with this cancer patient, buddy, you got some work to do.
And on that note, so at Cambridge, so Ben started his PhD he was already on the clinical program and did a secondment to do his PhD. And I think the whole department were utterly shocked at his ability to start programming and deploy some very sophisticated data science tools. So as someone who straddles both clinical and data science, Ben, I wonder what you think about winning trust.
I think interpretability is very important because from different fields, from different perspectives, there's an inherent prior being put through the training that's been done. I mean, not saying that medical training is exactly state of the art, because, you know, a lot of the things that you get taught in medical school, I would say, are pretty archaic and out of date. And sometimes even I query, you know, what's the evidence behind it? But a lot of the things just follow through and you still get imprinted into a way of thinking. And obviously, in order to adapt into something new, most people need, you can't make too much of a leap. You need to make a smaller enough leap such that is intuitive and interpretable. So as you know, for example, the retinal AI model that's been trained, obviously black box would be too much of a leap. But if you take a step back and if you mask certain places and be able to say these are the features in the retinal image that the AI model is considering, and these are different between cases and controls, then you can build that sort of the bridge to interpretability from the clinicians, because they look at it and go, oh, okay, that's also the area we focus on when we look at retinal diseases or other parts of a fundus, for various other things. And I think there's also that hand in hand where your sort of AI can be used to inform knowledge and in terms of accumulation knowledge and building on that, and vice versa. So at some point, there's things that wasn't understandable at the point, and then AI introduces some models where they picks up features that are not necessarily easily picked up by a human being or a clinician, but that are useful or have utility. And then that provides a training ground for people to look into those areas to see what are the interpretability gaps that we can sort of fill from a knowledge perspective. I think these things go, hand in hand. And also, as Paul said, once something's matured enough, you just don't question it. I think another field you could say is about self-driving cars, right? At the moment, would you get in one and just let it drive you down the motorway, or would you take your wheels off, of an all self-driving vehicle? Probably not right away. I don't know. I wouldn't. I'll probably still have my hand sort of vaguely on the steering wheel, not fall asleep. But still, it's one of those things that over time, once there's enough of a capacity that everyone's using and there's no problems with it, you adapt and sort of become acclimatized to it. I guess similar things with the aviation industry. Technically, probably a lot of the planes are on autopilot most of the time, but you feel more comfortable because there's a captain and a pilot there. Not necessarily they've got their hands on the stick all the time, but you just don't know that. But you assume there's that level of comfort when someone's at the wheel.
Very much like that. So I'll finish with a question that's, I think, very relevant for everyone. I'm going to start with Ricardo, because I know Ricardo's put in huge amounts of effort, along with many, many others, with Generation Scotland. And my question is, do we see much of the improvement in health outcomes and prognosis being derived from the principled development of biobanks and resources like Generation Scotland, UK Biobank, Fingen, Biobank Estonia, Japan, Biobank Japan, etc.?
Short answer, yes. I mean, I certainly think it might not be concrete, but we're definitely getting there. And I think another important thing to consider with these cohorts is kind of longitudinal sampling. If we're looking at response to drugs, or we're looking at the evolution of signatures over time, these are really critical parameters for us to consider. But yeah, I'd say I'm quite hopeful, and I think there's a huge amount of potential in the data that we're generating. I think also looking in terms of the solutions that are genuinely population representative, looking to Scandinavia, where there's these population-wide, so truly population-wide registries. In Scotland, there's potential for things like neonatal blood spots, which have been stored on everybody here since 1965. So like over 3 million cards on absolutely everyone. So it's, yeah. So you say more, I'm obviously going to say more data is better, but yeah.
Okay, so just a small riff off of that. Do we think the connectivity, what was your opinion then on a very focused collection of data on phenotypes from a particular population, like say in Finland or in Scotland or elsewhere, versus taking a more holistic or general approach? Or do you see that it's a bit of a divide and conquer, that you stitch together all of these principled frameworks that are designed for local populations?
Good question. I think it's going to be a bit of both, really. There are some things that are going to generalize well. I mean, we see that with some of the particularly the epigenetic predictors that we develop. They translate well from Scottish populations to people of Indian, Malay, and Chinese ancestry living in Singapore. Genetic predictors don't do as well across different ancestry groups. I think there's always going to be kind of local things to consider, whether that's pollution and environmental exposure in different regions, different dietary and lifestyle practices. So I think it's, there'll be some things that generalize very well, but others where they need to be tailored a bit more specifically.
Bro. Richard, do you want to come in there?
Well, I think, so there are 10,000 diseases, if you add them all up. I think AI and machine learning has a huge amount to offer. And you focus on the biobank angle of this. So what's likely to happen? I think most diseases that get around to being studied, and I think that will probably only be a few hundred of them, what's going to happen there? So I think when you look over the 500 diseases over the next 10 years that will be really analyzed very closely from biobank perspectives, and I think what you'll find is most of them benefit by incremental improvements. And I think occasionally there will be light bulb moments which transforms that therapeutic area into a new situation. But I think we will get multiple incremental increases, which after all is how medicine is always. There's a new technique, there's a new observation or whatever. So I think we'll have those incremental improvements in a lot of diseases by this approach. And every now and again you'll have a light bulb moment. And the other thing that I think will happen, if we're smart enough to pick it up, is that patients who somehow don't respond as expected, quite a lot of those, and there'll be different situations, but quite a lot of those will finish up redefined as a new rare disease, because they don't fit into that pattern, and they've been analyzed by the biobank and AI approaches, and they don't really fit. Their response is different. They've been too rare to pick up by individual clinicians, but you start adding them up, and it'll be redefining some diseases, and we'll be looking for new treatments for those. So I'm giving a decade-long look at this going forward.
So picking up on Richard's point, Ben, Heiko, how long until we find a biobank-derived, or we visit a biobank-derived Nobel Prize for medicine?
I don't know. UK Biobank has deserved one. I hope this will come every year. and similar these sort of approaches. So I just want to in general be. I mean, I fully appreciate being cautious. In principle, I think there are already quite some breakthroughs when we look at the biobank landscape. I mean, Ricardo is a very humble personality. I think he's understating a little bit that already just with an off-the-shelf proteomics analysis in this UK Biobank data, he was able to demonstrate that you have, of course, not yet replicated in a single cohort, and there's a lot of work that needs to be done. You can exceed the predictability with such off-the-shelf tool of an established biomarker that is being used in clinical practice since many years. So I think it is really a matter of how can we gain confidence that these type of analyses are really living up to what we see now in exploratory research, early observations, which we are really excited about. We do need to have good benchmarking exercises. We do need to have cohorts where we can replicate analysis. This will take a couple of years. This will require additional investments that will require researchers that are actually willing to do this type of implementation research, which will take probably a while to catch up. But I think the data sets that we already and the results that we're currently already working from have a very high potential to really massively transform how we are doing medicine and how we are approaching the discovery of novel drugs.
Absolutely.
And I guess lastly is just I think the main challenge is really being able to harmonize in the view of, data privacy and, that various form of geopolitical climate as well. I think obviously individual level data, confidentiality, identifiability are all issues, which makes me feel that, the importance of being able to derive summary level results such that we can still arrive at a mathematically approximate or equivalent solution without having to go back to individual level data, I think would be very important in plugging that gap, which, plugging or jumping between the walls that currently exist between different jurisdictions and between different cohorts and between different data warehouses as well. So I think enable to, the summarized method are very important in allowing for us to pull these things together, in addition to being able to do meta-analyses. So.
No, yeah, absolutely agree. And just for the avoidance of any doubt whatsoever, Ricardo's +1 to the Nobel ceremony has been already called by myself. So. Okay, so on that note, can I ask Daniel, Sarush, and Peter to come down? And just to say, I just want to say thank you very much if you pop down. Michael, I think you should probably present yourself as well, if that's all right. So all of the products that we are developing, the innovation, and to Paul's point about that principled engineering, and Manju mentioned it as well, that makes sure that we can achieve the goal that we've set ourselves, the very ambitious goal in bioXcelerate, is because of these people. And I'd also like to thank our very accomplished panel and speakers, and those who are thousands of miles away, and maybe, in the hundreds, Heiko, several thousand, but we can measure, we can be generous with our tens of hundreds. Yes, so thank you to everyone for a wonderful event, and that's us.
Thank you very much, all.
Thanks, everyone.
Thanks, Heiko. Thanks, Ben.